Good morning. Today we'll have a discussion on ward round scenario on abdominal trauma. Will presented by Dr. RM Jyoti, who is a third year junior resident at MR Bangur Hospital. And with us today is Professor Prashanta Kumar Bhattacharjee. He is Professor of Surgery at Arjikar Medical College. So, Jyoti, you share the screen and give the scenario
Okay,
and come to discussion. Dr.
okay.
Bhattacharjee will start.
Good morning, sir.
Yeah.
Good morning. Good morning.
A 32-year male with history of being physically assaulted presents in the ER with pain in left upper quadrant of the abdomen. On examination, his pulse rate was 120 per minute, BP was 100 by 60 mm of Hg, and on an examination revealed tenderness over left lower chest wall and rigidity and tenderness in left upper quadrant of the abdomen. Within an hour of resuscitation, with 2 liters of fluid, his hemodynamically stable, pulse was 84 per minute, and BP was 120 per 70 mm of Hg. What should be our approach to this patient? Yes.
Okay. I'm audible, no? Clearly?
Yes, sir. Yes, sir.
Okay. Now, when the patient was, I will go a little bit earlier. And now, when the patient was first wheeled into the ER, and suppose you are on duty, what was your approach to this patient at that time?
So, any patient with history of trauma, I will go with the ATLS protocol, sir.
Very good.
I'll go for the ABCD airway breathing, circulation, disability, and exposure in the primary survey. So yeah, I'll check for
so
the
what will be the simplest means of assessing the airway of the patent airway of the patient? The simplest.
Sir, asking just voice assessment. So if patient can say means its airway is patent and how mental.
Very good, very good. So if he can just speak out clearly and without any intonation. Okay, next.
So if airway is patent and then I'll check for his breathing, sir. Checking by physical respiratory, how chest movements and auscultation and the saturation pulse through bathymetry. And
the following this the primary survey as you're saying about the primary survey only. So
yes,
what are the just after the ABCDE, what else should you do?
Sir, if associated with resuscitation, I will continue with the ABCDs.
Yeah, the resuscitation should continue simultaneously. So what are any other baseline investigations that should be?
Sir, complete blood count, and I can send blood for blood grouping and cross matching if I'm suspecting any emergency hemorrhage like that.
And any other things?
Sir, in the emergency basement only, I'll go with the faster for any.
Very good, fast. And because we are talking about a scenario where everything is available. Okay, yes. So you have to do a fast and any other imaging that can be done in the emergency itself. You can do a chest X-ray. That is
arterial blood gas analysis.
Yes, okay, X-ray of the chest and X-ray of the pelvis, because that will rule out a lot of things, isn't it?
Yes, sir.
Yeah.
Yes,
so,
sir. Yes.
Yeah. What is the full form of FAST, by the way?
Sir, focused assessment abdominal sonar for traumas.
Yeah, focused
assessment for sonography for trauma.
For trauma. What will be the minimum amount of collection in the peritoneal cavity which will give a positive fast result?
Sir, minimum 100 ml of collection has to be there to.
No, more than 250 ml. Okay.
Okay.
More than 250. What are the areas where you should look for in fast?
Sir, right subphrenic and left subphrenic and pelvis and pericardium. Ziphiston.
4 P's. Remember 4 P's: perihepatic, perisplenic, pericardiac, pelvis. And what is E-fast?
Sir, when we see for the pleural spaces extended.
Yeah. What should be the approximate time that you should spend behind on fast?
So 10.
How much?
10 minutes.
10 minutes, not more than 60 seconds. Okay. You have to. That's the reason why it is also. It should be done very fast. Not more than 60 seconds. You have to just see these 5 areas basically. 4 P's and another P also, the pleural cavities, and rule out any collections there. Following these, what would be the predictors following your primary survey and your these baseline investigations? What would be the predictors of a possible intra-abdominal injury?
And Jyoti, another thing for first is, as per standard protocol, the first has to be done within 30 minutes of arrival.
Yes.
When the patient arrives to emergency, the protocol says that you should do the first within 30 minutes of arrival. Okay, so there is a one protocol for first.
So what would be the 30 minutes of arrival? What are the predictors for intra-abdominal injury following your primary survey?
Sir, if patient is not hemodynamically stable, I mean, even the continue with resuscitation.
No. What are the predictors? Like, for example, in this patient, already we have mentioned about 2 or 3 things, like if the patient is having pain and tenderness on abdominal examination.
Okay,
yeah. If the
patient is having tachycardic and hypotensive.
Before that, anything in the history, anything in history will suggest patient has got abdominal trauma. History.
Sir, mechanism of injury.
Yes.
Yeah, starting from the mechanism.
He was beaten up and he got sustained trauma in this particular part of the abdomen, lower chest. So history of the injury is important. And what else? After the injury, what symptoms he may have which pertains towards abdominal injury?
So pain abdomen, abdominal distension, and
yes.
Any swellings and any external injuries directly related to the abdomen.
Yes. On examination, there will be tenderness of the abdomen, lower chest, maybe because of associated fracture ribs. Then on inspection, there may be some contusions on the abdominal wall, isn't it? And the X-ray, if it suggests that there is a pneumothorax because of left-sided fracture rib, that also suggests maybe there may be an underlying splenic injury. All right.
Yes.
And any other things, because you have sent these baseline investigations?
Sir, hemoglobin and WBC count and
yes, hematocrit. If the hematocrit is less than 30%, and obviously you have done a fast, if the fast is positive, these are the predictors that the patient may be having some intra-abdominal injuries. And what will be the indications, or what are the indications for a immediate early laparotomy in these patients?
So, depending on the mechanism of injury, if it is direct penetrating injury to the abdomen.
No, in this particular patient, the patient has come to you.
So, if patient is hemodynamically and
unstable,
if this patient is unstable and any signs of peritonitis have developed.
Very good.
And patient is having fast positive.
Positive. Very good. Or any other associated injuries.
Fast positive is not always the indication of laparotomy.
Not always. Positive.
With
that is very important.
instability.
What happens if you do laparotomy in each and every case of positive fast?
Sir, maximum most of the abdominal injuries can be conservatively managed.
So there will be an unacceptably high rate of negative laparotomies. Okay.
Yes.
All right. So in this patient, you had done a fast, and there was some free fluid in the left upper quadrant of the abdomen, and we said that the following this initial infusion of IV fluids around 2 liters, patient was hemodynamically stable. So what does that indicate? Is there any message behind this line that you have said?
So patient might not be having ongoing bleeding. Patient might have.
If the patient can be stabilized by, that is the protocol. If you can stabilize the patient hemodynamically after 2 liters of ringer lactates electrolyte infusion, then you can categorize the patient into the stable group, because you have the treatment protocol depends upon whether the patient is stable or unstable.
Yes.
Okay.
Yes, sir.
So now that the patient is stable, you have categorized the patient to a stable group, and with some amount of intra-abdominal injury because there was some collection in the left upper quadrant on fast. What should be the next line of management from your side?
Before that, Jyoti, suppose you have this blood pressure on giving this fluid. After 2 hours, there is a drop of blood pressure again to 100/60.
Yes.
Yes, sir.
What does it mean?
So this patient may be transient responders.
So what are the transient responders implication?
Initial, so the clot, because of hemodilution, the clot which is formed may get dislodged.
Hey, that means what?
No.
You have given the patient a
Coagulopathy.
fluid challenge.
That.
He has come up, but after 2 hours on maintenance fluid, he has gone again down. That means what?
So patient is having the ongoing bleeding, but it's stabilized with the responder. But
he's a transient responder. Transient responder indicates that there is a evidence of continuing bleed.
Continued bleed, yes.
So that you have to keep in mind.
Yes.
Yes, proceed.
So next imaging, what should you do?
Sir,
patient is now stable.
Patient is so I can proceed with the contrast enhanced CT.
Yes.
For delineating.
Next best investigation would be the contrast enhanced CT scan. What informations can you gather from a contrast enhanced CT scan? In general, I'm talking about, other than this particular patient. Yeah. What are the information? Yeah.
Any intra-abdominal collection of fluid, any free gas can be.
Pneumoperitoneum.
And retroperitoneal injuries can be assessed.
Very good. Next, hemoperitoneum, pneumoperitoneum, then visceral injuries, laceration,
yes,
yeah, or devascularization even. Anything else? Laceration, contusion, devascularization, retroperitoneal hemorrhage, subcapsular hematomas, pneumoperitoneum, isn't it? Hemoperitoneum.
Yes,
these are all the information that you can gather on CT scan. Okay, very good. So now that you have done the CT report is available to you, and you find that the patient is having grade 4 splenic injury.
Yes.
Okay, grade 4 splenic injury. What do you mean by grade 4 splenic injury? The radiologist has
if hilar or segmental vessels are affected, and there is devascularization of spleen about 70 up to 75% of.
Can you please repeat? I couldn't get you.
Sir, hilar or trabecular vessel injuries leading to devascularization.
Hilar vessel injury. Leading to devascularization of how much?
Is it a shattered complete devascularized spleen or?
No, sir. Up to 75%. Up to 75% of the spleen.
No, 25%. More than 25%. More than 25% of splenic devascularization. That falls under the category of stage 4.
Yes.
Okay.
Yes.
Or if there is an intraparenchymal hematoma which has ruptured and there is an active bleed, that will also be categorized under
grade 4.
Grade 4, yes. Now you find in this particular patient that there is a 30% devascularization and there is a contrast blush, as it is called, contrast blush on CT scan. Okay, grade 4 splenic injury, 30% devascularization, and there is a contrast blush. What should be your approach?
So if patient is hemodynamically stable.
Obviously stable. In this particular patient, he is stable. And these are the findings. Grade 4 splenic injury with 30% devascularization and some contrast blushes there.
Sir, as patient is similar, I will go with the conservative approach only, sir. And
what?
Recently,
what approach?
As patient is having a contrast extravasation, I can go with the, if radiological intervention is available, I will go with the angiographic embolization of the.
Very nice. You will go for angioembolization. Any role of angioembolization in grade 5 splenic injury where there is complete avulsion of
as there is shattered spleen, so it can't. In
shattered spleen, yeah, but not necessarily always that grade 5 should have a shattered spleen. That is one criteria. Other is there is complete avulsion of the from the hilum. That is also grade 5. Okay. So is there any role in of angioembolization? Suppose the patient is having, it is not a shattered spleen, but just avulsion from the hilar avulsion.
So and there is no continuation. It's a donor.
Okay, you can still go for angioembolization because spleen can survive with the other vascular connections that it has got from the ligaments. But because of the ongoing bleed is there from the hilar avulsion, that bleeding should be stopped by angioembolization. Okay.
Okay.
Yeah. Now, what are the complications? What are the problems with this angioembolization?
Sir, It may get fail sometimes. It's difficult
It may
to sometimes
yes,
reach the vessel also. Access is
there may be other vascular injury during access. There may be even splenic infarct, isn't it? Splenic
yes.
abscess. These are the complications of angioembolization. So what are the other indications for non-operative management of splenic trauma?
So if early grade injuries like grade 1, grade 2, grade 3, then we can go for non-operative management. And if patient is, even though it's grade 4 also, we can, if patient is hemodynamically stable, we can go for non-operative management.
First thing is that patient should be hemodynamically
stable.
All the grades can be done, non-operatively. But just angioembolization increases the possibility of the
conservative management.
Yeah, conservative management. So the hemodynamically stable. Any other?
No signs of peritonitis.
No, very good. No signs of peritonitis or other intra-abdominal injuries. Anything?
Associated injuries also we have to rule out.
The patient has planning for conservative. Yeah, patient has not received more than 2 units of blood. Stabilized, with less than 2 units of blood transfusion. And on subsequent follow-up, patient is not deteriorating. As Professor Shah was saying, that the patient is not deteriorating. Okay. Yes. On subsequent follow-up of the patient. How long should you keep the patient on follow-up before saying that the non-operative management has succeeded?
So depending on the grade of injury, we'll add for grade 1, grade 2, we'll add 1 day for follow-up, and for grade 4, there is 2 days extra.
No. Usually the failure occurs within maximum percentage of failures occur within.
I don't know.
Within 72 hours. Failure, if it is a failure of conservative management, most of the time it will occur within the first 72 hours. You can understand if you keep the patient under close observation for 72 hours and patient's condition do not deteriorate, you can say that most probably the conservative management, non-operative management has succeeded. Okay. But even beyond 72 hours, how long you should keep the patient admitted and then keep the patient under observation?
Sir, with serial investigations and if patient is improving.
Yes, patient is improving, patient is not deteriorating. Okay. So you should keep the patient admitted for around 7 to 10 days before you can discharge the patient with certain advices. Because most of the time, if the failure occurs, it occurs within 72 hours. You are going beyond that to about 7 to 10 days. And if the patient do not deteriorate within 7 to 10 days, you can discharge the patient, stamping that the patient has succeeded with non-operative management. Okay. And when would you say that there is failure of non-operative? What are the criteria for failure of non-operative management?
So if patient is requiring more than 2 units of blood transfusion, and patient is vital parameters are deteriorating, and patient develop any signs of peritonitis. Very
good. And one more point that should be remembered, that you should go for non-operative management only if you have got a very good, CQ, well equipped with adequate staff and availability of an operation theater 24 hours a day. Okay, 24 into 7. Okay.
Okay.
These are the criteria that should be there first and foremost before you can go in for a management, non-operative management of splenic trauma. All right.
Yes, sir.
Now, if the failure occurs, of course, what should be your option?
Sir, operative management.
Yeah, operative management. What are the options?
Sir, it can be depending upon after expiration of the abdomen, depending on the injury, we'll go with that.
Bolo.
Sir, what are the options? Just first tell us what are the options for operative management of splenic trauma. You open the abdomen.
Yes, sir.
What are the options?
It can be simple suturing, sir, splenography, or partial splenectomy, or total splenectomy.
Partial splenectomy, total splenectomy, Splenography. Okay. Followed by, if you have done total splenectomy, anything else that you can do to at least keep the patient to some extent immunocompetent?
Yes, sir, vaccination or antibiotic.
On table.
On table.
Yes, sir, a replacement of fluid tissue in the greater omentum.
Yes, you can create a pocket in the greater omentum, and fragments of the spleen can be
placed
splenic slice graft.
Yes,
splenic slice graft.
Okay, now you have done a splenectomy, and you are keeping the patient on watch. When would you suggest that the patient is probably developing a post-splenectomy sepsis? In other words, what are the?
Sir, I didn't.
You didn't get me. What are the
Sir, I didn't hear.
You have done a splenectomy because of the failure of non-operative management. You have done a splenectomy in this patient. You are keeping the patient regularly on watch, and when would you suggest that the patient is developing a post-splenectomy sepsis, which is a very dreaded complication, isn't it?
Yes, sir. The patient is developing any fulminant infection, which is insidiously, and patient is developing vomiting and dehydration.
No, there are some criteria. Like, for example, if beyond 4th day, if the patient is having a WBC count of more than 15,000 or a platelet is to WBC ratio of less than 20. Okay. That is the criteria for post-splenectomy sepsis. All right.
Okay.
And clinical features of fever.
And clinical features of fever.
Fever.
All right.
Okay, sir.
Okay. Like any other major surgeries, patients sometimes develop post-operative thromboembolic manifestations. Now, this patient was having this bleeding, and but still, you require post-embolic prophylaxis in this case in the form of low molecular heparin.
Sir, in post-operative patient, there may be a thrombocytosis, so leading to so patient needs leading to thromboembolic.
Embolic features. So what should you do, and when should you start?
So low molecular heparins can be started on the post-operative as a prophylaxis.
Yeah. When? What should be the optimum time for starting the post-operative prophylaxis, thromboembolic prophylaxis? So it should not be delayed beyond 48 hours. You have to start within 48 hours. Okay.
Okay.
Because it has been seen that if you delay it beyond 72 hours, then the chances of thromboembolic manifestations will increase. So it should be within 48 hours, preferably within 48 hours.
Okay.
Next, about immunization. You are talking about something about.
Jyoti, what is the explanation for rise of platelet count following splenectomy? Why does the platelet count rises?
The sequestration has been because of removal of spleen.
Yes. So spleen is a site for platelet destruction.
Yes.
So once the spleen is not there, these platelets are not destroyed. So there is more platelet circulation.
What are the other functions of spleen?
Sir, immune functions and phagocytic function and filter functions for any hinge bodies like that.
And hemopoiesis also. That is a site for important site. Okay. Now you are talking something about immunization. What is the optimum time for immunization? This is a very important question that is sometimes asked.
So in case of emergency laparotomy, emergency splenectomy, we can give after 2 weeks of.
Yes. Why not immediately after, as soon as possible, rather?
So immediately, as patient is having immunologically less competent. So.
Very good. So it has been found that if you give the immunization at around 2 weeks post splenectomy, the immune response is far better than if you give it in the immediate post-operative period. Very good. Now, finally, tell us something about OPSI. What is OPSI?
Sir, overwhelming post-splenectomy infections. due to as a spleen, as after removal of the spleen, there is phagocytic function of the spleen is lost. So there is increased infection with the encapsulated bacteria with Neisseria, pneumococci, and influenza organisms.
Capsulated organisms. Very good.
So vaccination has to be done against these organisms to avoid
how is it very
and
common?
antibiotic.
Is it very common?
If
it's not very common. It is not very common, but it is very lethal. Okay.
Yes.
It is lethal because usually they are resistant to all antibiotic therapy. So that's why it is very lethal. So every measure should be taken to, avoid it. Isn't it?
Yes.
Okay.
Professor Shah, any other questions?
Yes. So what I'm trying to say is this patient has got a blunt trauma in the abdomen and you suspected splenic injury. Okay. What are the usual modes of presentation? Patient has suspected splenic injury following a rotary accident. What are the usual groups of presentation that patient has got splenic trauma?
Yes, the patient may present with classically with generalized peritonitis and.
So one is classic features. Classic feature. What are the classic features for presentation following splenic trauma?
The patient is having general signs of shock and localized features of splenic injury. The local features like tenderness in the left upper quadrant and abdominal locally rigidity and presence of any is diaphragm left shoulder irritation.
So classic feature is once the patient's splenic injury, patient may have features of shock. So patient may have shying respiration, tachycardia, hypotension. That is one part. Second part is patient has some symptoms because of the splenic injury, because of bleeding, because of hematoma. So pain, swelling in the abdomen, there is ecchymosis in the skin. And on examination, he may have tenderness. There may be isolated rib fracture, or patient may have isolated left-sided hemothorax or pneumothorax. What may be the features? Yeah. What may be the features if you take just a plain X-ray? What may be the features if you just take a plain X-ray and you suspect that might be some splenic injury? There are some suggestions. There are some findings. There are some findings in plain X-ray in splenic trauma. What are those?
So if patient is having any left-sided lower rib fractures,
yes,
and patient in X-ray showing any homogeneous opacity in the splenic left upper quadrant,
yes,
and if patient who suspect if any hematoma is there, and the funding gas shadow may shift to medial
indentation of funding gas shadow.
And what about any other gas shadow?
There is the colonic flexure may.
Left colonic flexure gas shadow may be pushed down.
And obliteration of
obliteration.
Yes. So one should see carefully in the plain X-ray even, where you may have some suspicion. So what do you mean by another group of patient with splenic injury may be a group that has silent presentation? What are those patients?
The patient is having splenic injury, but patient usually have symptoms of only pain, mild pain in the left upper quadrant. Rest of the on clinical examination and baseline investigations, if patient is normal.
Yes, these happens most of the time when you have got a subcapsular hematoma, which is not expanding. So there may be a group of patients with splenic trauma where the presentation may be just a vague presentation. There is no classic features of splenic trauma. And what can happen? Why you are keeping the patient for about 10 days till patient is being discharged there? There is another mode of presentation.
Delayed presentation can be there. If
delayed rupture.
Delayed rupture of the subcapsular hematoma. So, hemoperitoneum can be formed because of rupture of the.
So following the trauma, patient was stable.
Yes.
Patient was stable and there is no specific symptoms and signs of splenic injury. If you do imaging, you could have diagnosed that patient has got a subcapsular hematoma. And then after a variable time of 7 to 10 days, patient may suddenly deteriorate with pain abdomen, features of shock, and then all classic features of splenic trauma. So
one thing should be remembered here, that there is a difference between delayed rupture of spleen and delayed diagnosis of splenic injury. Okay.
Yes, yes.
Yeah, because as sir said that some patients sometimes one of the presentations may be left shoulder tip pain. Patient has undergone a
Yes, sir.
trauma. He had come to a GP with history of this shoulder tip pain. Okay, left
Yes.
shoulder tip pain. And the GP thinks that maybe because of the trauma, patient is having pain in the left shoulder tip. So he prescribed some analgesics and let the patient go. So these are the patients who were basically was not imaged also. So that is
Delayed presentation.
Yeah, this is the delayed diagnosis of splenic injury. And the other thing is, what is by definition, what is the delayed rupture of spleen is that you are detected the patient is having a splenic trauma by imaging, and you had kept the patient on non-operative management, and then suddenly patient deteriorates, as sir said, suddenly patient deteriorates, and because subscapsular hematoma ruptures, and that usually occurs within beyond 48 hours of that injury. And initially there was no such complaints actually. Suddenly patient deteriorates, and even sometimes it happens so that it was not detected also. This even following imaging, injury was not detected, and then suddenly after 48 hours patient succumbs because of this rupture.
Patient has got a blunt trauma abdomen, and you have suspicion of splenic injury.
Yes.
You have done a plain X-ray of the chest, and you find there is also a saphrenic free gas. What should be the strategy for managing these patients? The background of suspicion of splenic injury.
Sir, associated maybe hollow viscous injury can be present.
So, strategy in this case would be?
Like, going the laparotomy.
Yes.
Yes.
Resuscitate and go for laparotomy.
Yes.
Suppose on laparotomy, you find that there is a lower polar splenic tear which is bleeding.
Yes, sir.
On laparotomy, there was a small gut perforation. You have repaired that, and as soon as you find there is a splenic trauma, lower polar injury which is actively bleeding. How will you manage that?
So if polar tear which is bleeding, we can go with the partial splenectomy.
Or you can go for splenography also. So if you are planning to do splenography, what are the steps? If spleen is where? Spleen is lying depth in the left hypochondriac region.
Yes, sir.
If you are planning to do a splenography, what you have to do? What are the steps
of the spleen
for
into
doing
the
spleen? Yes, how will you mobilize the spleen?
Sir, we have in emergency splenic any treatment of splenic condition, we have to mobilize the spleen into the wound by dividing the lateral, starting from the lateral side, dividing the white line of told, and then going upwards up to the esophageal short gastric vessels.
What is that maneuver called?
Sir,
Mattocks. Very good, very good. On the right side it is?
Cattle brush.
Cattle brush. On the left side it is mattocks. Very good.
So what you have to divide? What ligament you have to divide to deliver the spleen to the wound?
So white line of told and splenorenal ligament we will divide, and we will create a blunt space.
So the most important step for doing a splenography or polar splenectomy is one has to mobilize the spleen, brought it out of the wound, and then you decide what to do. Either do a splenography. How do you do splenography? How is splenography done?
Sir, by matrix suture we will keep with the.
So you can apply matrix suture over a piece of momentum or a piece of
plates.
You have to compress the spleen so that otherwise if the spleen is in the normal position, if you try to pass the sutures, it will cut through. So you have to compress it like it is like a sponge, isn't it? Compress it and then put these horizontal matrix sutures.
Any local hemostatic can help in controlling the bleeding?
The Surgi cell can be, if it is not.
Any local
any other thing.
Any other local hemostatic agents like oxidized cellulose like Surgicel and
Anything else?
Fibrin glue.
fibrin. Yes.
That is a very good agent which can control bleed from the liver or even the splenic trauma. Okay, you can use fibrin glue. And these local anesthetic like Surgicel or oxidized methyl cellulose. Okay.
So what is a lethal triad? I'm just deviating from the main thing. What do you mean by a lethal triad?
So it is a triad of hypothermia, acidosis, and coagulopathies in case trauma
In
patients.
case
Trauma. In case of trauma with when we go for
in case of trauma. Okay. So to avoid this lethal triad in case of a blunt trauma abdomen with massive injuries inside, what should be the approach?
Sir, to avoid a hypothermia, we will go with cover with the warm blanket. Patient has to be covered with warm blankets and warm crystalites we have to give. And to avoid acidosis, we have to.
How do you prevent coagulopathy? How do you prevent coagulopathy?
The coagulopathy, it has.
One reason for coagulopathy is what?
Dilutional coagulopathy is the reason for because so transfusion when patient is requiring massive transfusion, we have to go with the massive transfusion protocol of 1:1:1 ratio of PRBC platelets and
so the concept of crystalline resuscitation is not favored now. Yes. If you have a patient has got splenic injury or liver trauma with hematoma in the peritoneal cavity, the basic management should be more of blood transfusion than crystalline infusion. Yes. And in the blood transfusion should be 1:1:1 of PRBC and FFP. Okay, so coagulopathy is protected by this.
And what else? So you have to treat coagulopathy. Anything you have, as you said, you have to warm up the patient to correct the hypothermia. Any surgical, the patient is bleeding inside, isn't it?
Yes, sir. If patient is damage is hemodynamic damage control surgery.
What do you mean by damage control surgery?
Sir, damage control surgery is just we have to control the hemorrhage and treat the prevent the contamination.
How to control the hemorrhage?
So if patient is having any intra-abdominal, suppose like solid organ injuries and venivascular.
Yes.
You can ligate the vessel or
ligation. You have to pack the 4-quadrant packing.
Packing 4-quadrant.
Yes, 4-quadrant packing. If
the background of bleed difficult to ligate. Right,
yes.
Damage control is you pack and come out.
Yes.
You pack you achieve hemostasis by packing. If there is open gut injury, you have to you can even just simply use a stapler and cut the ends and keep it stapled. Because you're going to go back once again, isn't it? Not necessarily that you repair. In case you want to repair, you just roughly repair it. There is just close the rent, or you use a stapler, remove the the damaged segment, keep the 2 ends stapled, put the gut inside, and then you
temporary closure.
No, don't close the abdomen. You put some there are materials which are available with which you can cover up the gut, and don't try to close the abdomen, because patient, as sir was saying, patient has already received lot of fluids, and that causes swelling of the viscera, the liver, the intestine. These get swelled up, and that if you close the abdomen in the background of these, what will happen is
abdominal compartment
the patient will develop abdominal compartment syndrome. So after you have done that, you shift the patient to the intensive care unit. Try to break this lethal, the vicious cycle of acidosis, coagulopathy, and hypothermia by keeping the patient warm, correcting acidosis, correcting coagulopathy, and then shift the patient back again to the operation theater, preferably
48 to 7.
Not 72. 72 will
48.
be a bit too late. 24 to 48 hours. As soon as this cycle is broken, okay.
Yes, sir.
And then you can go for the definitive. Yes, sir was saying something.
And the most important thing for damage control surgery, the principle is you control the bleed by packing.
Control contamination.
And number 2, control the contamination.
Yes.
Okay, that is the 2 basic important aspect of damage control. And once you do this, you buy time. You buy time and resuscitate the patient and go in again.
Yes. I think she has replied excellently. All the questions she has answered.
She is good.
No,
Dr.
no way.
Maiti.
Yes, very nicely answered, Jyoti.
Thanks.
Almost all questions answered with precision, to the point answering also. Excellent discussion. And
Thanks.
in this relation to the splenic injury, the common thing, some common terms, lucid interval, that should also be remembered. And during clinical examination, you also ask whether there is any history of hematuria present or not.
Yes.
Because
Yes.
associated renal injury is not so uncommon. In 2 to 5% of cases, there will be associated renal injury.
Okay.
Excellent discussion, excellent question answering session.
Any question from any of the participants?
Good morning, sir. The grades of splenic injury, they are measured by CT scan or what? Like
Grades of CT scan is by CT only.
liver injury also, any kind of
Yeah,
yes.
city.
Yes, ultrasound can give you an idea about the injury, but the exact grading is not possible in ultrasound. The CT scan will give you the good idea about the staging of grading of the injuries.
Professor Shah and Professor Bhattacharya, regarding type 5 splenic injury, it was discussed that there is scope of conservation of spleen. I think most
Type
of the
5
time,
is for surgery only. Difficult
and
to manage.
splenectomy is the answer. Probably there is no scope of continuing the conservative treatment if it is type 5.
It's a very severe injury. Yes, medical avulsion means patient is difficult to manage, and most of the patients don't have facility for the radiologic intervention. And most of the time, for radiologic intervention, patient has to be again stable. For doing a radioembolization, patient has to be stable. A unstable patient cannot be sent to radiological suite.
Yes.
So when the patient comes in the emergency, if the patient has associated respiratory distress with means like in left-sided pneumothorax, sir, that patient is sent for X-ray or sir fast.
You see, fast is done at the bedside. Keep in mind, for doing a fast, we don't send the patient to the radiology department. That has to be done bedside. Number one, if that is another important point. As I always say, after the primary survey, before the patient is shifted out of this emergency bay for investigation, you have to exclude some life-threatening conditions like pneumothorax, massive pneumothorax, and pericardial tamponade. These three life-threatening situations has to be addressed before because if you send the patient there, this patient will die because of tension pneumothorax. So if you have a subsequent tension pneumothorax, assess it clinically, and you can put a tube just based on your clinical assessment, or if possible, get a chest X-ray done. You cannot send the patient to a CT scan suite.
Okay, and sir, within means fast takes about 60 seconds, but within what time should we conduct the fast? Is there any time?
With 30 minutes. The standard protocol is the fast has to be done within 30 minutes of arrival in emergency.
During the damage control resuscitation.
Yes.
Okay, sir.
Someone has asked if there is a fecal contamination, whether to do colostomy or not. You see, in damage control, as you already said, it is not doing a colostomy. Colostomy takes you time. In damage control, you close the rent end. The rent that is there, you just close it either by staple or by suturing, and then come back. Don't do a formal colostomy while you are talking of damage control measures. Damage control measure is prevent contamination by closing the rent. That's it. And go in again up to 24 to 48 hours. Any other question?
Sir, one more question, sir. Sir, if the patient is hemodynamically stable, means we have stabilized it with 2 liters of IV fluid within 1 liter, and we have done fast. So then should we go for WBCT, means whole body CT scan again?
You see, if the patient is stable and fast is positive, try to understand. The first is positive, and there is some suspicion of underlying visceral injury.
You must do a CT scan. Yeah.
Okay. If the patient is stable, there is no positive fast features, abdomen is soft,
then need not.
That everyone has to undergo a CT scan.
And that is not recommended also. Yeah. Routine CT scan in all patients is not recommended.
No. You have to have some. Fast is very important.
Fast should be done. Yes.
Fast and then continuing observation. You see, a patient may not have features of this injury on arrival, but on continuing observation about the next period of 3, 4, 5, 6 hours, this patient may show some new features. There will be some appearance of new signs. In that case, you need to do a CT scan. First is not assessment of the whole abdomen by ultrasonography. You see, there is always a scope for doing ultrasonography of the abdomen, where you assess the liver, you assess the spleen, kidney, and the whole of the abdomen. You see, first is not assessing the abdominal viscous. You can go for ultrasonography if you have a patient where you are not planning for CT scan.
And there are situations also where the ultrasound may not give you information, like if the patient is very obese, if the abdomen is too much distended with gas-filled intestine. Okay, in those cases, fast may not be very informative.
False negative.
Yes, yeah, there may be a false negative fast.
Okay, sir. Sir, and during such splenic injury, while we maintain the patient on conservative management, when do we do the next CT scan?
It should be daily ultrasound.
CT scan is not repeated regularly.
Serial CT scan. Basically, it is a monitoring by doing serial ultrasonography.
And blood investigations like the hematocrit, hemoglobin, hematocrit.
You cannot do a CT scan every 24 hours.
Yes, sir. Sir, in many books, sir, it is written serial CT, so that's why, sir.
Serial CT is not every 24 hours. It can be monitored with ultrasonography, and if the patient is deteriorating, you can do a CT scan and decide accordingly.
I will upload a paper from the United States, the guidelines, where it is clearly mentioned that you should not unnecessarily do CT scan because it can be very damaging to the patient also. I'll upload at the end of this session. I will upload it into that.
Oh, thank you, sir.
CT scan also needs the transport of the patient from the ward to the CT scan center, but ultrasound can be done also on the bedside.
On the bedside itself.
It is intentionally mentioned that either it is serial CT or ultrasonography for monitoring.
Usually the CT scan, when the patient is on conservative management, CT scan you can undertake at weekly interval if needed, if you are needed. Otherwise, as Professor Shah has mentioned, the ultrasound examination and most important is the clinical examination.
Yeah.
Once you have get the ultrasound findings on the first attendance or second time ultrasound, next most important thing is the clinical judgment. Clinical judgment is the most important once you have established the preliminary diagnosis by first.
Okay. We will discuss other injuries like liver injuries and kidney injury in other session. So today we have discussed on more details about the splenic injuries and the approach. Okay. So basic approach, you should always keep in mind that whenever you have a trauma scenario, you should always keep in mind that you will go by the HLS approach and then proceed to the routine management of specific injuries. Poshak, any last minute comment?
Hello.
Yes.
Hello. Discussion is fine. Only one thing I am asking: in a stable patient, is there any role of diagnostic peritoneal lavage?
Actually, with fast diagnostic peritoneal lavage is a very important investigation. With advent of fast diagnostic peritoneal lavage is not indicated now because it's a number one invasive investigation, and even if you find it's a positive. Previously, DPL positive was taken as the indication of laparotomy. With advent of conservative management for splenic and liver injuries, even if the first DPL is positive, there is no role that you should go for laparotomy. So now more and more patients are evaluated by first rather than DPL.
I want to add a few words. Hello.
Yes, please.
Actually, in our setup in Calcutta, we don't have a ATLS advanced life and trauma support team in a hospital, but in Western countries there is a ATLS team. When this
we have now in SSK and other places.
Most of the medical colleges.
so what I can tell from my experience that one such patient reaches the emergency by an ambulance crew always inform the emergency medical officer that we are coming with such patient or a airlifted patient, and then through the switchboard the ATLS team automatically gets the blip. ATLS team automatically gets the ATLS team consists of surgeon, anesthetist, physician, emergency doctor, and a radiologist also. So they come immediately to the field. So there is no confusion. I think from the discussion there is a little confusion. How we will do the fast and this and that. It is not like that. Whole team will reach within 10 minutes there. Whole team will reach, orthopedic surgeon. So whole team will reach there and they will do the drill along the ATLS protocol.
Actually, Dr. Bosak, I agree with you that we don't have such dedicated trauma center in all over West Bengal, but we are coming up with such trauma centers in SSKM. The protocol I mentioned is what we exactly follow. Okay.
No, I agree with you on that. But from the discussion, I thought that the boys are a little bit in dark because they don't practice the ATLS thing. So that is why I added these few words.
For exam, they have to be ready with this. This is exam scenario.
In the exam,
Thank you very much.
Dr. Bosak, actually, in this particular case, it was a ward scenario, and that ATLS teamwork and what should be done in the field. I think Professor Saha can organize another session for that. What should be the management in the field, say, including the pressure bag and so many things. I think that ATLS teamwork in the field, that we can organize a session, a seminar like that.
This is a discussion on a clinical scenario.
In the world.
Yeah. In the world.
Admission,
For the student.
Now, after admission, what happens in the ward? Actually.
Yes, that's right. Okay.
Thank you very much. Thank you all the participants. We'll meet again on Saturday. Thursday, sorry.
Thank you.
Thank you.